Hello, everyone. My name is Natalia Saukova, and it is my honor and pleasure to welcome Dr. Radek Munajed today in IADS Educational Webinar. Welcome, Doctor.
Hello. Good evening all over the globe. I'm very happy that we solved the connection problem, because I was going to say, Houston, we have a problem. And I hope that we will enjoy this evening. We will have a presentation about preparation. I don't know if you want to say anything else, Natalia, or you give me the word and I can just continue.
I just apologize for the technical problems we had, but you may start. We're really excited to hear your lecture.
Okay, I heard that there's a lot of people from all over the countries, and there's people from Nepal, from Macedonia, from Jordan, from Egypt, from Rwanda, which is my dream to visit Kigali. For that, I was very excited when I heard that there's somebody from Rwanda. I will now start to share my presentation. Just give me a few seconds, and we will be there. Okay, just tell me, Natalia, when you will see my presentation.
Sure. For everyone, just so everyone knows, after the presentation, you may give any kind of questions through the YouTube, and I will then ask them, Doctor, to answer those questions. So you can be free to ask, feel free to ask.
Okay. Okay. Do you see now the presentation?
Yes, we may start, Doctor.
Okay. Once again, I'm very sorry also with the organizing group that there was some technical problem, and we will start immediately. I will speak about preparation. Nowadays, you see a lot of people speaking about minimally invasive preparation and fixed prosthodontic. It's something, it's evolution in prosthodontic, that we are trying to do a minimal harm to the tooth structure. But at the end of the day, we are trying to reach the same. That means we are trying to prepare our tooth if we need to prepare them. I have a concept which I call the smart prep. That means prepare what you will need. Don't prepare a lot if you don't need to do it. That means we need to understand why we are doing the preparation. What is our goal? And this is what I will speak about today. I will speak about, I will show you a lot of cases. I will show you a lot of videos, and we will be, at the end, having some question. The question is why we are doing preparation. It's always a question. We have two reasons. The first one is to rebuild the function of the tooth. That means we have a lost function, like the tooth is destroyed and it's not having its function anymore. And the other one is saving an existing function, that we are afraid that the tooth will crack or something will go wrong. For that, we try to save this function. As you know, as a students, the tools have three types of function. The first one is mastication. That's when you need to chew and bite over your tooth. The other function is phonation. That's when you use your frontal teeth for speaking. If you don't have tooth or teeth, you will not be able to pronounce the word correctly. And also aesthetic is also a very important one of the three functions which we have with the tooth. That means even we have to restore the mastication, or to restore the phonation function, or to restore the aesthetic, or we are restoring all of them. This is one reason why we are going to prepare a tooth and just to restore one of those three functions. The other thing, we are afraid to lose the function of the tooth. That means we are afraid that the tooth will crack or something. And for that, we are covering it with some type of restoration like onlay or like full veneer crown. what will affect the preparation design? Like if we are designing a preparation, is our goal a crown or a bridge? Are we plan to do a crown preparation, or the preparation will be just a part of a bigger bridge? It's also affect the design of the preparation. The other thing is, what is the amount of destruction? Is the destruction small or big? That's mean if I have a tooth with a minimal destruction and we just need to save it, we don't need to destroy the whole tooth and to rebuild it with a new crown if we already have it. And this is, I will speak about very in a long way today. And then we need to understand the restorative material we are going to use. If we are going to use a full ceramic material or a metal crown, like a gold crown, or any other type of base metal restoration, or a ceramic fused to metal, that's mean even the material will decide the design of my preparation. You know that when we are doing preparation, we hear a lot about the biomechanic of tooth preparation. That's mean, what is the meaning of biomechanic of tooth preparation? We are removing the structure of the tooth with the mechanical instruments, like rotation instruments, and replace it with material which need to have mechanical stability in the mouth of the patient. That's mean if you look at the picture on the right on the screen, you will see a very minimally prepared tooth, and we produce a space for our future crown. That's mean I need this space to be adequate for the new material. If we are using, let's say, gold crown, it will be enough to have, let's say, half millimeter of preparation. If you will have porcelain fused to metal, you will need like 1 millimeter or 1.2. That's mean the design of the preparation, the removal of the biological material from the tooth structure, replacing it with the artificial structure, ceramic, metal, or composite, will decide how much I will need to remove. The other thing where I will design or where I will put my finish line, to put it supragingival, subgingival, echigingival, this all decide how my preparation will look like. And I will show you a lot of picture, clinical picture, then you will be able to understand it more. A very important part, and I will show you some video about that, is where to locate the margin, because most of the people think we need to locate the margin subgingivally. But this is, to be honest, not true at this day, because subgingivally, according to the age of the patient, sometimes we don't have any more enamel. It's always good to keep the enamel, and I will show you. This is just a small introduction before we enter inside the subject. That means you agree with me that we need to restore or to save the function of the tooth. Don't forget, we have 3 functions of tooth: mastication, phonetic, and aesthetic. Even we are going to restore them because they are lost, or we are going to save the tooth because we are afraid to lose this type of function. And always students and doctors ask me in the conference and in the meetings, what is the best type of preparation? How I should do it the best way? And if there is any key, like what we should do, I have one very clear answer for this. And this answer is, the best type of preparation is not to prepare at all. We don't want to prepare at all. If I am able to do it with evolution, that will be great. You understand from my word, the less I prepare, the less harm I do for the tooth structure, the best I can provide to the patient. Please remember that tooth structure is like the forest in Amazon area in Brazil. Once you remove it, it's not there anymore, and it will not grow back anymore. That means if you remove an enamel, it's a precious structure which we need to deal with it like with a diamond. We really need to be very precaution about removing excesses part of the tooth and destroy the tooth. Natalia, everything is okay? You hear me well? Natalia?
Yes, perfect. Everything is perfect.
Just let me know if, because I don't have any response back for that. I'm just to be okay that everything is okay.
Everything is perfect. Continue.
The question is how to be aggressive. The aggressiveness of the preparation is one of the biggest disaster of dentistry, because a lot of dentists, they just come to the patient come to the dentist, and when he see the tooth and see that the patient would like to have some type of crown, he just see money, he see dollars and euros, he just want the patient to pay, and he start to drill. The best thing, as I told you, is not to prepare. For that, we have now a very modern concept which called non-preparation approach. Like if you look on the left side of the screen, we see two premolar. This is two premolar for a patient, and on the this is on the left side without any veneer, and on the right side you can see two premolar with two veneers. This is how the patient looked like. I did for her some restoration in the frontal area, and on the left side you can see how the aesthetic is not sufficient. That's mean at this point we want to restore the aesthetic function of the tooth, because to be honest, number first and second premolar on the left side of the screen, if you look at the picture, this will not affect the phonation. This will not affect the mastication. But for this patient, it's very important to restore the aesthetic appearance of her face, of her smile. She's not happy. And if you look, you see that the tooths are pushed inside. That means we need to augment them. We need to increase the volume of the tooth in the direction of the vestibular direction. And why to prepare the tooth and to push them more inside if we want to withdraw them up? And on the right side of the screen, you can see the smile of the patient with two non-prep veneer. That's mean I restore the function of aesthetic for these two teeth, and there was no need for preparation. This is, of course, an ideal way of working, and we have only small amount of cases can be solved with non-preparation approach. That's mean we restore the function and we didn't destroy any of the tooth structure. And this is very important. Before you hold your handpiece in your hand and you start to remove the structure of the tooth, really think about it, plan how your design will look like. Also, the engineer, before he starts building a house, he draw on a paper a plan for his house. He don't immediately to start and ask the worker to put the wall here and there without no planning. As a dentist, we are engineers, we are architects of the smile. And to be a good architect, you need to have an idea what you are going to do. Because anything you remove, anything you destruct, it will not grow anymore back. I believe in a minimal preparation. Keep the preparation only in the enamel. All the picture which I am showing you here, it's my own picture. I didn't use any picture from internet, from any. All the pictures is from our clinic, from the DCM clinic, where I'm working in the Czech Republic. And some people say, hey, but when you remove just a little amount of tooth structure, like you see on the picture for this premolar, it will not stay. If you do a crown, it will not work. They teach us in the dental school that if you are doing a full ceramic crown, you need to remove 1.5 millimeters. Please, this is history. Also, in the old days, when people were traveling from city to the city, they were taking horses. But now they are using a speed train. But the sad part in a dental school, at some places in the world, even here in the Czech you can find it, they learn the students that if you want to do a full ceramic crown, that's mean no metal, only ceramic, you need to remove 1.5 millimeters. This is a history. This is not true anymore. You can do a very conservative preparation for this type of restoration. For that, if I am indicating a full ceramic crown, I know that I'm indicating almost no preparation. This is a very minimal invasive preparation in the enamel, and you can find in a publication like from Cortellini and his group that's really acceptable and it can work very well. And the type of adhesive restoration like lithium disilicate restoration, Emax, can work really beautifully. This is the preparation on the left side. It's a tooth after endo treatment. There was a very deep caries, and I was afraid that this tooth will crack, because as you see in the left side of the screen, there is a small crack in the tooth. This is a non-vital tooth after endo treatment. And here, the function is existing, the aesthetic was okay, and the patient was happy with the tooth, but I was afraid that the tooth will crack because it's non-vital tooth. There is no more flexibility of the tooth. For that, I am trying to save the function of the tooth, the mastication and the aesthetic. In premolar, phonation is a little bit less important than when you are, like, for example, restoring a frontal area. On the right side on the screen, you can see the crown in mouse after 3 years of function, and I save the tooth, the patient is happy with it, and I hold all my preparation in the enamel. Okay, that's mean if you take another restoration, I'm really trying to do a very simple preparation. Please, these pictures are, you see the rubber dam, but I installed it when I was planning to fix the crown. I don't make my preparation under the rubber dam. It's only I put to see how my preparation is big or not, but I didn't prepare the tooth under the rubber dam. I use all my burrs, which I use for preparation. They are only measurement number 10. That's mean 1 millimeter in wide. I don't use 1.4, 1.6 because I don't want to destroy the tooth. All my preparation, which I am doing, I'm starting with red diamond. That means the roughness of the diamond is red. I don't use black, I don't use green, I don't use blue, and I will show you later on why I'm not using this rough, coarse diamonds, because that will cause a lot of distraction to the tooth structure. That means I need to be very gentle to the tooth structure, not to make more harm than benefits from the work. This is another type of my preparation. This is a periodontal probe. I do all my preparation under loops, under microscope. And this is one of my old preparation, like 10 years ago how I was working. This is how I was preparing very aggressively with blue, green, or black diamonds. They are indicated with the, you know that the most coarse is the black indication, then you have the green, then you have the blue, then you have the red, then you have the yellow, then you have white. White is a very smooth diamond. And do you see on the enlargement of this picture, this micro crack in the enamel? This is because I was using a very coarse diamond. This was prepared with the blue diamonds. And when you do it in a high speed of instrument, you see a small cracks. But when we were not using a microscopes, we didn't see it. But when we start to use microscope, we start to see our cracks happening during the preparation. I noticed the cracks when I was putting my pictures in one of my presentations 10 years ago. And you can see it. and it can't be smooth anymore. It just cracked. It's a weakness, a part of the whole thing. And this is on this picture. Do you see exactly the course? This is the blue diamond is down. On the upper part of the screen, on the left side, you can see the yellow, and little bit more coarse is the red one on the right part of the screen, upper right part. The problem, even with the preparation, when I'm going to prepare the tools, always I use a new diamond. The problem is that the diamond's particles will be, the spaces between them will be filled with the debris from the tooth preparation, and they start to be inactive, and they only increase the temperature of the tooth. And this can make very big harm to the pulp of the tooth. For that, I advise to use a new diamond always before starting a new preparation on a vital tooth. I know it seems strange that you need to, but really it's make a big difference. Since I stopped using black, green, and blue diamonds for preparation, since I start my preparation with a red diamond, since I start always to use a new diamond for each patient, since I'm doing a lot of cooling, I really don't have a problem with pulpitis after preparation. It's a very rare now the patient come to you with some big pain and asking you that he have a pulpitis and you are forced to do an endo treatment, because our goal is to keep the tooth vital, not to do an endo treatment on a regular basis, because also endodontic treatment can cause complication. You can have a tooth root fracture. You can have a fracture of the instruments during endo. Endo is a very difficult discipline in dentistry, and if we can avoid it, let's avoid it, because I believe in, as much as you keep your work and treatment simple, as much as you will have a very high success rate. The most you complicate your treatment with a very complicated preparation, a lot of endo, a lot of stuff, then you can have bigger chance for okay. Everything is okay. You're still on air with me, right?
Yes.
Hello?
Yes.
Oh, okay. Okay.
Great.
It's very
Go
strange
ahead.
because it's very strange. I'm just speaking in front of the screen, you know. I don't see any reaction. It's
yes, there's
bit,
no feedback.
it's no feedback. For that, just I put my phone on. If something go wrong, just send me a message, and I will stop. I will show you this patient. This is a young lady. She came to my office asking me to do something to her. I said to her, "What's your problem?" This is how she came to my office. She said to me, "I have a lot of pain." I said, "Okay. And any other problems?" She said to me, "Yes. They did for me a veneers, and the veneers, they are still falling down all the time. The dentist, he glued them on, and they fell down in a few weeks or a few months. I can't stand this anymore. Please help me somehow." And I look at the preparation, at the restoration we have. She came to me like this. Two of the veneer, as you see on the right side, prepared tooth with no veneers. Some of the veneers are there, and I will give you some detail of the preparation. I was very surprised from the not accurate preparation, and what I did, I just removed the old veneer out, and I discovered that the preparation was very aggressive and went through the enamel to the dentin. And as you know, if you are doing adhesion to the enamel surface, your adhesion will be much more stronger and stable than when you are doing your adhesion to dentin. This is true. This is evidence-based dentistry, nothing else. Even the dentist who was doing the treatment, the strange thing, if you look at the like from the appearance, tooth number 11, according to the FDI, you can see that some of the preparation were taken in the tartar, in the stone, in the deposits. That's mean he was even preparing and putting the margin of the veneer in a tartar, which is very strange. What we did, we removed the whole old cement. This is how it looked like when I removed the old luting cement from the surface of the tooth. And I discovered that the preparation was so deep that she had a pulpitis, and we were forced in some of the teeth to do endo treatment, which was very sad because the patient, she is like 22-year-old when she came to our office. This is how it looked like. This is the detail of the preparation. You see a very big layer of cement, and it's not working. And you see how we have a lot of debris. And we decide to do a full crown, because if you don't have enamel, you can't do veneer, please. If you don't have enough enamel, at least 90% of the surface is not enamel, it's contraindicated to do veneer. You need to do crown, a very conservative crown, but crown. Because there is some studies, as you see here, from this study from 2012, there is reasonable evidence indicating that the veneer preparation into dentin adversely affects survival. This is evidence-based. This is the reality. That means if you don't have an enamel, don't plan to do a veneer. You need to go for crown. This is reality. For that, I do a full I do a full veneer crown preparation. This is the impression. You will see a lot of video how I'm doing the preparation, and I will learn you how to do a correct preparation. This is how we did the new crowns over the teeth. We did the central incisor, lateral incisor, and the canine. Now it's in function like for 3-4 years, and it's working well, and the patient is okay. Sometimes we are struggling with hygiene. She wasn't this type of patient taking a lot of holding a perfect hygiene, but the hygienist is taking a very good care of her. And this is her smile. I start with this case because I want to show you that how a design, bad design of preparation, and then a bad type of work will lead into adverse effect for the patient. That's mean at the beginning, why they removed the enamel if they were planning to do aesthetic veneer. I don't know why. This was the first mistake. At the second stage, if they enter the dentin, at this point they should not do a veneer but a classical crown. Then, if they decide to use a full ceramic, like in this case, then we can remove less from the tissue. If they are planning to do porcelain fused to metal, that PFM, then we need to remove more from the structure. As I told you, 1 to 1.3 millimeter. That's when you need to have more space, because you need space to the metal and space to the ceramic. In this case, you need only space for the ceramic. Okay. Always you need your preparation to be beautiful, clean, and smooth. You don't need to do a rough, a very aggressive preparation. You don't need to enter your border very deeply subgingivally. This is not true. We don't need to push to the edge of the crowns subgingivally, because it will be very difficult to do an impression. It will be very difficult to remove the residuals of the cement after gluing or cementing the crowns. For that, for me, always, I like to keep my border outside. And if you are using a metal-free restoration, then you don't need to hide everything under the gum. You just can keep it outside a little bit. And as you see, the central incisors, we have a crown on the canine. On the right side, you can see a preparation for a veneer. On the other side, you can see a preparation for a crown. That's mean I design what's suitable for this case. It don't mean I need a crown or I need a veneer everywhere. No, I put the veneer where I should put it when I have a lot of, I need to restore the aesthetic, and I put the crown when I need another result from the restoration. Always we need to study and to be we need to know what material we are going to use before we are starting to do the preparation. It's very important you understand the material before we go for the preparation. I know we don't have the time today. I'll be more than happy for you as a students to do a full presentation about ceramic, about classification of ceramic, that you can easily understand how to choose the correct material. And then another presentation can be even about cementation of the crowns. But we can't, of course, put everything in one day. That's me learn about the material. Really, they look very similar. Once I arrived to the airport, and when I was waiting for my bags, I saw this, and I said, when I was looking at the bags coming out, I said, oh, this is exactly how the student see the material on the market. Very similar and very difficult to distinguish from one material to another. A lot of students have a very big, but not only students, even a practitioner, they don't know the exact difference between high, low side ceramic from the lithium disilicate ceramic. It's always very, very difficult. How to make a decision? A lot of things which affect your decision is the investment, the money, how much the patient will pay, how much you will gain money from that. It's sad, but it's always the decision. If you are going to buy a car, you will decide what type of car you will buy according to the amount of money you have. The same thing for the patient. According to his money, you can decide what type of restoration is suitable. It's sad, but this is the reality and this is the life. The other thing, sometimes the practitioner get in love with some of the material. If somebody is in love with Emax, with lithium disilicate crown, he will just say, this is it. I just want to use it here and here and here and here. Somebody else from an older school will be happy to use a gold crown, and he will use it, and he will convince you this is the best thing. That's me mostly if the dentist is happy with the material and he like it, he will use it very frequently. And other thing is how do you find it in the literature? How is the experience with such material? For me, it's always the most important issue is how, if I have any evidence-based stuff, I can use it for my material. We need to know the mechanical properties of the restoration. We need to know the aesthetic outcome. We need to have a very easy manipulation. That's in all this stuff will affect the material which we are going to use. And according to the material, we will design our preparation. It's very bad to start to do preparation and at the end you decide what type of material. I want you to do it in a reverse way. That means the moment you start to prepare, start to think what will be a very clever choice for me. If you are doing a crown in the posterior area, in a very deep preparation, just go for a metal crown or for a ceramic fused to metal. You don't need to use a full ceramic in number 7 second molar, very deep preparation, because you need to do an adhesive cementation, which is very difficult to do it if it's somewhere very deep, subgingival. And that way, I will use a simple crown with no adhesive cementation, like metal ceramic crown. For me, a very choice number 1. After all of this, you saw how we choose. And now I will show you a case. I will show you some video. This is a patient with two central incisor after endo treatment, a very big restoration, and we are afraid that this tooth can break. This is number one. That means we need to save the function of the teeth, which is aesthetic and phonetic, because as you know, central incisor will affect the phonation of the patient. You can't speak if you don't have tooth, but also you can smile if you don't have tooth. That means we need to address this point here. Other way, I have some part of enamel. If you look at the picture on the left side, you see on the right central incisor, the less colorful one, you can see that we have some enamel, and it will be good to save it. When I start to discuss with the patient this case, I say to him, if we hold our crowns in the enamel, we will have a very good outcome for the future. But I will not be able to cover exactly the color tooth on the left side. That's in the dark tooth will be very difficult to cover if I will keep the enamel, because I will have a very thin preparation which can't hide the color of the tooth. Since the patient have a very low aesthetic line, that's mean when he smiles, you don't see the neck of the neck of the teeth, then I don't need to make an aggressive preparation, and I will show you how it. This is X-ray before, this is X-ray after endo treatment. I'm doing in my practice only prosthetic work. I'm just doing prosthetic reconstruction. In our clinic, we have 2 colleagues doing endo treatment, and we have another partner. He's doing prosthetic with us, and we have a surgeon, and we have a hygienist, and the whole amount of staff in our clinic is like 28 people working at the DCM clinic. And I'm doing only the prosthetic part. Oh, I will just remove the music. I'm sorry. Okay. Okay. Okay, now you can see how we will do the preparation. I am starting with burr number 10, that's in 1 millimeter wide, red coarse burr. Natalia, we see good, the video is okay?
Yes, everything clear.
Everything clear.
Okay, and you see what I'm doing? I'm starting to locate my margin supragingivally. You need to keep space between the gingiva and between the margin. Don't go directly down. Just keep it a little bit up. If you make a small mistake, then you can correct it. But when you go immediately very close to the gingiva, then it's very, very difficult to do it. In my case here, I decide to keep the border supragingival as much as I can. And I use a very thin burr, like here you see, just to remove the contact point. The video is a little bit distracted by the internet transmission, but I think it's okay. You can see it well. Most important, never touch the adjacent teeth. When you do it, you are dead. You are destroying the adjacent teeth. And if you didn't solve it somehow, like by polishing, then you will have a caries in the future. At the end, you take a diamond band and try to remove the contact point with it. You see, I am very gentle during preparation. I don't want to see bleeding. I'm not killing the tooth and the gum, like to see bleeding, like if I'm doing some bad stuff to the tooth. Everything needs to be clean. The patient needs to have a good hygiene. We don't start to do any preparation, any prosthetic work, if the hygiene, the level of the hygiene of the patient is not adequate. We just don't do it. We try to remove as less as we can. You see here we are using this circles just to smooth, and slowly, slowly. We are not in rush, we are not in race. It's not true that the quick doctor is the great doctor. No, the doctor who gives a very perfect crowns which will last in the mouth of the patient for a long time, that is the good doctor, not the quick one. The quick one is not a good doctor. The good one is who is calm and doing the work with patient and slow, and how you see how I'm putting the instruments not to hit the adjacent. Now in the mirror with indirect view under the microscope. Here I decide to go a little bit lower down, just a little bit, because this is the tooth which is darker and I need to minimize the dark part of it. And you will see how we'll do the impression and you will see the result. This is a 0.5 millimeter, and you see now, I will just, you see the small amount of dentin which was, oh, now you see the pointer, I think, right?
Yes.
You see the arrow, the black arrow on the screen or not?
Yes, we do.
Yes, we do.
Okay. Now we polish. I always like to polish my preparation because polishing is a very important thing. Because when you have a polished surface, then your impression will be very easy, because you need, when you are removing the impression material, to be very smooth. And because we are doing adhesion at the end, adhesion cementation, that's mean we don't need to have a rough surface. The more smooth surface you will have, the more accurate impression you will have. It's very important. I always like to polish my preparation. This is a very big enlargement. This is like magnification, 20 magnification. It's really a very big detail under the microscope. I just want you to see what we are doing. And we polish, we look at it, we will be almost at the end. Now we do our retraction, just to see the border. If it's bleeding, we put this astringent gel. It's a special materials. A lot of companies produce it. You will just put it and it will just stop the bleeding. After that, you wash it out and you need to see the space for the impression. You see how the impression material, we use the A-silicon, polyvinyl silicon, A-silicon, polyaddition silicon. We blow it with the air because we don't need to have bubbles, and we take the impression. Okay. This is the second version. For that, we didn't remove the. I will also show you something. I know that in this video, I will only show you once again the retraction. Maybe we'll go to the end. You see how we put the impression. Now we blow it. I will go back with the video. What's very important, I will stop the video here. When you are putting the, when you are putting the impression material, always put it under the shoulder, under the preparation line, and under it. Never put it from the up, do it under, then you will have a more accurate impression. And after that, you put the upper side, like always put it under the preparation line, then you add the silicone over, and they will connect together and you will have a very beautiful result. When you have this, then you take your impression tray and move it up and down, up and down. By this, you will disturb, you will remove like shaking movement of the tray. By this, you will remove the bubbles from the impression. This is how my technician give me the work. You see that, you see how, I will try to see if we can see that. I don't know if we can see it on this. Okay, you can see how my preparation is very supragingival. you see the less colored tooth is more supragingival. The more colored, I put it more near to the gum. And on the right side of the screen, you can see the rubber dam in place, and I am going to fix my crowns. Here I need to clean my preparations, my abutments very well. We use the airflow for that. We clean it with the airflow. We remove all the debris. And one of the benefits also of polishing the surface of the tooth is when you are removing the provisional crown, it's very easy to remove the residuals of the cement, the provisional cement, because if you have a rough surface of the tooth, you will have a very hard day to remove all the pieces of the cement. For that, polishing and smoothing the surface is really very useful. This is how and now you can see on the left side, we isolate the adjacent teeth with Teflon, and you can see small places. I will show it to you. Small places, okay, because I want to show you with the arrow. Okay, small places of dentin. You see the dentin here? This is after etching the enamel, and you see this is a small pieces of dentin which went out, and I try always to keep my whole preparation in enamel, and it's difficult, but with time it will come and it will work. This is how the patient look like with the crown, and you can see on the right side how the border is supragingival, but it don't matter. You don't see it because my crown is very accurate, and your crown will be very accurate. For that, you don't see the difference between the tooth and the crown. And this is great. That's means even I didn't push my border under the gum, but I still have a very aesthetic outcome. And of course, this is a magnified picture. And this is the smile of the patient, and he is happy with this, and it's working for, I don't know, also this case. Most of the cases I'm showing, it's like 2-3 years. Only some of the cases. This is a very tough cases. We have an all-two crown, which I remove. I did preparation here. We have one very dark tooth, very resistant for internal bleaching. That means sometimes you are not able to do an internal bleaching. And I don't like to exaggerate with the internal bleaching, because if you exaggerate with internal bleaching, you can also have internal resorption of the root. For that, don't do it. We can't hide it with some type of material if we prepare a little bit more. But this preparation is very aggressive. But there was an old crown. For that, I'm not able to remove what was destructive before. On the right side, the right lateral incisor, you can see is less color, it's less dark. For that, there is no need to push the crown, the border very beneath the subgingival. And if you look at the picture, this is after I insert my first retraction cord. The whole stuff is I insert the first retraction cord during the preparation, and after that, when we finish everything, we put the second retraction cord, and you will see how. This is when we are removing the second retraction cord. The first retraction cord is non-impregnated retraction cord. It's just a dry retraction cord, mostly measurement 0 or 1, not more. And it stays inside the sulcus of the surrounded tooth through all the time of preparation. There is no rush to remove it. You just keep it there the whole time. But please, don't forget it. Sometimes it's happened to me that I send the patient back to home, and after that, we remember, oh, we forget the cord inside the mouth of the patient, and we start to call the patient. Be careful not to forget the thin retraction cord 0 or number 1 in the sulcus of the tooth. And after that, you put the second retraction cord. And I will learn you now how long you can keep the retraction cord inside the sulcus. Forget about this theory that you can keep it only for 2 or 3 minutes. No, you just keep it longer. And I will show you in a few seconds, some pictures demonstrating how the gum will return back normally after some time, even when you keep your retraction cord long time in the sulcus. I keep the second retraction cord in the sulcus for 15 minutes. And it's working. There is no rush to remove it in 3 minutes, and I will be very happy if somebody will have any question. Now, when we are removing the retraction cord, put a little bit of water over it. When you start to remove the retraction cord, please moisture it and gently remove it. If you don't put water, you can cause bleeding. For that, moisture the retraction cord, and you will see that you will remove it, and your sulcus will be open like a big door, and you can see inside. There is a rule: what will your eye see, your impression will see. If you have a bleeding, you will not be able to take a correct impression. What I do, I remove the second retraction cord, as you see here. Look with the mirror on the preparation, check my borders, then I start to put the silicone, the impression material. I never do that removing and in the same time I'm putting the impression material. Just remove it, clean it, brush it, look at it, then put your silicone. You see, we just remove the retraction cord out. And now we have an open sulcus. We have a very obvious open sulcus. And now the impression material can go very easily inside and can take a very correct impression. If you will not have a good retraction, you will not have a good impression. If you don't have a good impression, you will not have a good master cast. If you don't have a good master cast, you will not have a good crown. If you don't have a good crown, you will not have a reasonable working crown, like you will have inflammation, caries with time, and this will be very bad. Now we are applying the silicone inside the sulcus. As you see, we are pushing it in a very pressure inside. If there is a bleeding, before you start application of the silicone, just don't do the impression. Put some of the hemostatic solution or any of the hemostatic paste, stop the bleeding, and then continue, clean it, and then continue with impression. When you have a bleeding, it's very dangerous. Even if you see the other lateral incisor, there is a small bleeding in the sulcus. This can be a very dangerous if it's more. We put it, if there is need, we just blow the air just to push the silicone inside. If there is no need for, if you are aware that there is no bubbles, there is no need for blowing the silicone. You see how we blow it inside, we put another layer, and then we take the impression, and we see very beautiful impression, which will lead us to use a very, okay, we have some, and now we see the crown. One crown is very much, one retraction is, you can see the border on the right side more, the left side is more subgingival. This is how we are inserting the crown, just to try them. But always when we are fixing a crown, but of course we don't have time to do it, we need to fix each tooth single. We never fix 2 crowns together, never do it. If we have 10 crowns, I fix each crown separately. Fix it, control it, then try the contact point, because the contact point is a very big issue during fixation. This is how it looked like. Now this crown, they are in function for 6 years. The patient is doing fine. And it like last month he was for a regular checkup at the hygienist, and I watched up and this picture is really after like this picture is something about after 4 years of using of the crown. This is what we need to do, and we need to have a good technician that we will able to produce a nice crown. This is a very old case I did. This is like 10-year-old case. But I like to show it because from old cases you learn. I never like to show a case which I did yesterday because I'm now working for 22 years and there is a lot of mistakes I did during my professional life, and I'm trying to tell you where I did the mistakes, because by mistakes we learn. But always it's good if I'm looking at this preparation, it was at that time it was good, but it was for these days it's a little bit aggressive. But we have a very nice. This was my start of doing a little bit supragingival preparation and aggressive retraction. And now look, now you will say, wow, what he's doing. You will see. I removed the second retraction cord. We still have one in the sulcus, and I kept it there for 25 minutes. You see what you have between the two incisors? It looked like the gum, the papilla is destroyed. This is how the impression was done. I'm using for 10 years the same impression material, silicone. This is provisionals which we install to the patient after preparation. And look, on the right side is a picture of when we remove the retraction cord immediately before impression. On the left side is when the patient come for the new crowns. This picture was when I removed the provisional crown. You see how it's healed, how the gingiva look nice. This case demonstrates that there is no problem by leaving the retraction cord longer time inside the sulcus. Of course, you need to take in mind that according to the biotype of the patient, you can keep it more or less. Like if you have a very thin biotype, you can't keep it for 20 minutes. But it needs another presentation about this. If you have a thick biotype, like a lot of connective tissue, then you can keep the retraction cord for longer time. This is how it looked like. Of course, also the provisional crown needs to be accurate, need to look, don't need to have excesses border, which will destroy the gum. This is how it looked like when we remove the retraction cord, and on the left side, you can see how the gum is doing really good. Now we are going to fix the crown. At that time, okay, sorry. Oh, yes, okay. This is when we try the crown. This is when we fix them, the day of fixation. And this is how the situation look like after like 8 years in function. You see the papilla, it's working, or 7 days. This is day 1. It's not beautiful crown anymore. We do much more beautiful crown now. But at that days, this is how we were working. And on the right side, you can see how the crowns are working or doing after 7 years. It's a gummy smile. When the patient is just talking, saying to you, good morning, you can see the connective tissue, the connective gingiva. It's a very difficult type of patient to treat. When you have somebody who you almost don't see his tooth or teeth, then it's very easy to do it. But when you have somebody with this gummy smile, it's really very, very difficult and very stressful to treat him. But you see, when you look at the gum, it's a thick biotype. It's not a thin biotype. I don't know if you are familiar with the expression biotype. We can speak about it later if we have time. This is how the patient comes. This is how what we did for her, and she's happy with that. I know that we can do much more beautiful crown these days because we learn a lot with the lithium disilicate these days. But at that time we were starting with them, and it was really a very long battle before we understand how the lithium disilicate look like. We need to make a very good polishing of the preparation, like you see here. Always when we are doing polishing, please, we need to cool it with water. No increasing of temperature of the tools, because if you don't cool it with water, then you will have a very increasing of the temperature inside the tools, and you can have pulpitis. And also be careful of you know it, like you need the instrument not to be stopped by a hook. We called it in Czech okap. It's a hook, and it's always when we finish preparation, we do this. And if you see that the instrument is stuck in there, then you take some instrument and you smooth it, and it will work. Everything is okay? You still hear me?
Yes, we're all here. Yes, we're all here.
Okay.
Listening.
Good. I will show you some case also. We remove a provisional crown from the patient. And when we remove this provisional crown, I found that the tooth is almost, a lot of preparation was done on this tooth. For that, I decided not to increase anymore. What I put a non-impregnated retraction cord inside the sulcus. I inserted inside, all surround the tooth. Cut it and hide the ends inside the sulcus. This is retraction cord number 1, non-impregnated. We do it immediately when we are approaching with our rotation instrument, cutting instrument, to the area of the gum. And after that, when you finish preparation, like here, you put the second retraction cord. The most important thing is that when you are putting the second retraction cord, you need not to lose it inside the sulcus. Always you need to see it a little bit outside the sulcus, because if you push it all inside, the sulcus will close and you will not have a good retraction. You need to keep 1/3 at least of the retraction cord outside. If it's not, you need to make another turn with the retraction cord, because at the end, before leaving the retraction cord, you need to see it. We will have some video. And when you finish everything after the preparation, like after the impression, then you remove cord number 1, the non-impregnated. If you put only one retraction cord, you will have immediately bleeding before impression. It will be very difficult. That's me. You put the first retraction cord, which is not impregnated. I'm sorry, I will just, okay. You put the first retraction cord. You put the first retraction cord. Then after that, you make a preparation. After that, you put the second retraction cord. Keep for 15 minutes, you remove the second impregnated retraction cord, you do your impression. When your impression is finished, you remove the first retraction cord. And now watch it with a little bit music. You can see it. And you see the smooth preparation. Very smooth preparation. You need to stabilize your hand. You smooth everything. You need to use your loops or microscope. Okay, now you see how we remove the retraction core. You see, when we remove the retraction core, we have an open sulcus. We clean the preparation with microbrush and we put the silicone material inside. You see inside the sulcus. Very good. Very good. Now you move, you see how I move the impression tray like up and down, and by this you just remove the bubbles and you see a very clean impression, no bubbles. In the lower jaw, we had also one old crown, we just remove it. There is a lot of preparation, we clean it. This is a very big magnification. You can see the local anesthesia, you can see the blood vessels. And now we put the first retraction cord and we discover that we don't need more retraction. We don't need to push the preparation more deep. For that, we didn't use the second retraction cord. Just one, the first one, the non-impregnated, and we leave it the whole time inside. And we have the impression, you see? Very good. Okay, my son is asking me if he can use the Skype during the webinar. I said if we will have problem with the speed internet, he will just stop the Skyping with his friends. Okay, this is a very big congress we have, and you are all welcome to Prague, the Dental Summit. And we do a lot of live show. And you see here also, sometimes we are not able to do retraction with retraction cord, and we use the electric current to do retraction. It's also one of the methods to clear the view, surround the borders of the preparation, surround the margins. Also, you need to be very gentle, because sometimes when you have an old crowns, the preparation is deep, it's very difficult to use the retraction cord. In this case, you can use the electric current. This is how I look at it during preparation. You look in the mirror, under the microscope you do the preparation. It's bleeding. For that, sometimes you need to put the hemostatic, but it was previously prepared. For that, it's a little bit, and you see how we are removing the decalcification here. You see the white spot. We need to remove it because this can cause a caries in the future. And when we finish everything, we see if we don't have hooks, this is a big preparation, all retracted with electric, no retraction cord. And to stop the bleeding, you see how it looked like, a very clean preparation. Okay. Sometimes we just go inside in a deep area only in some proximal areas, but when you don't need, you just keep the margin outside and you go inside only if there is a caries or something. That means if you start to go inside subgingivally, that don't mean you need to do it all surround the tooth. Sometimes you keep some part out, some part inside, if it's clear. And at the end of the day, the most important part, to have a very clean impression and a very clean master cast. If you have a clean master cast, as you see on the right side of the screen, then you can have a very accurate crown, which will have a very good prognosis. This is how the master cast needs to look like. Always when the dental technician, which is a very important part of the whole work, need to model the crowns in a way that the patient in the future can insert the interpraxal brushes between the tooth and clean well the teeth. This is how it looked like. You see, and we have something outside. If it's outside, that means we have an enamel and we can have adhesion. This is a space for the proxal brushes. And now we are going to fix the crown by adapting and rubber dam. If we are able to adapt the rubber dam, we will do it. If not, we need to find a different way of adhesion. You can do an adhesion process without a rubber dam. That means if we are doing adhesion, we need a rubber dam. If we are not able to put the adhesion, then we need to find a different way of cementing the crown. And there is a special protocol which I have for cementing. I will show you another case. A tooth after trauma. By the way, this is one of my colleagues. She's a dentist. And this case is new. We did it at the Dental Summit live. That means I was doing the preparation with a direct transmission to the hall where there was like 800 people watching. And she was the patient and she's a dentist. It was a hard day for her. And we did also a very simple and very gentle preparation only inside the enamel, as you see. And this is a very difficult because when you are doing only one side central incisor and you need to match it with the other natural tooth, it's really very, very difficult to do it because you need to find a way how to do it. This is how we are fixing. You see the preparation, all it's done inside the enamel. Only also we have a small spot of dentin. This is how the crown is thick. You see, this is a full ceramic crown and the thickness is 350 micron, because as you know, 1 millimeter is 1000 micron, and this is less than a half a millimeter. That means this is 3.5 millimeter in the thinnest part. This is how the crown look like. This is, I think it was a very beautiful job from the side of the dental technician working at our place. This is the work of Jakob Exner, his name is. And this is how it looked like when the patient came for a regular checkout. And you see, this is when the patient is counting, and she said, 1, 2, 3, 4, 5. You see, this is what I'm always asking. I'm looking at the patient from one side to the other side just to see if it's look natural. Because always I'm asking the patient to come for a regular checkup after, let's say, 1 week to 2 weeks, just to see if everything is okay. And this is on the left side. If you look at the crown, the picture inside the mouth of the patient, this is how it should look like. A very clean gum, no inflammation. You don't see the border. Everything is clean and neat. And as you know, this is outside the gum. It's not inside. The border is, it's not subgingival. It's a little bit and this is what I try to explain for you today. I wasn't, because normally we stop the presentation and we speak and we answer for that. I didn't know how long it will take. I don't know how much we still have. Okay. And I will be more than happy now when we will finish. All the cases, when we are doing them, we need to be very gentle during preparation, as you see this. This video, I put it like few days on the internet on some of the groups. And this is a patient with 4 veneers we did for her. And we give her some veneer. And everything have end. And the most important that we give the patient the best service. We don't make bigger harm than they have. And always remember that when you are treating a patient, imagine yourself sitting in the dental chair or somebody from your family and ask yourself a question. If I am the patient, would I like to be treated in the same way I'm going to treat my patient or not? If yes, you do it. If you are lying on yourself, try to change your attitude, because it's a very non-ethical if we are doing some treatment, for the patient and we know that we will never accept to do it for ourselves. For that, I'm refusing to prepare healthy teeth just for some type of veneer. And mostly the veneer even look more ugly than the natural tooth. Because if you do a veneer for somebody who is 20-year-old, with time, the veneer will become ugly. You will need to change them in a new veneer, maybe in a crown, and you are destroying the structure of the tooth. For that, always, but always, ask yourself, if I am a patient now sitting on the chair, on the dental unit, will I accept to have this type of preparation in my mouth? Will I accept to have this type of crown in my mouth? If not, you just do a different way. And I will now go back to the camera. Sorry. Okay. Do you hear me?
Yes, thank you very much for a lecture.
I'll be very happy now to... do you see me? No?
Not yet.
Not yet. It's... Okay.
Do you have your headphones somewhere around?
No, I have a... I don't know why. Maybe I need... If I go out and log in, is this a problem or I can log once again? I think we are there now.
Yes, it's perfect. Yes.
Oh yeah, I'm here now. Okay.
But do you have your headphones somewhere around you? Just so
no,
the
sorry.
audience wouldn't hear me.
I have only... No, I don't have the headphone now with me. I think the children... Okay, I'm sorry for that. But if you just tell me the question, I will directly try to answer to it.
Okay, so we have first question.
Yes.
Sandra. Yes, in minimally invasive preparation,
Excuse me, in minimal invasive preparation, I didn't catch the word.
Whether you never root for
You know,
prior.
okay, it's not like this. Our main goal or an ambition is to keep the tooth vital. If we are able to do it, we are very safe toward the pulp. As that you see, for example, that the 2 central incisor, which I did a crown for it, it was almost after endo treatment. That's mean I did a minimal invasive preparation, even after endo treatment. That's mean our goal, if the tooth is vital, to keep it vital. And if the tooth is non-vital, trying to keep the enamel. This is the philosophy of the minimal invasive. It's very easy just to drill it all very quickly and aggressively, and this is it. But what we will gain from that? The fantastic about the new material, which we can adhese them, like we can do adhesive cementation, like we can etch the enamel, we can etch the ceramic, and we can cement them together with the adhesion. This is where we can do minimal invasive restoration. If you can't do this, for example, with zirconia, you can't etch the zirconia because there is no amorphous glass inside the ceramic. The amorphous, it's a polycrystal ceramic. That means no amorphous glass. And you know that the ceramic, we have three types of ceramic. The ceramic with high content of amorphous glass. Then we have ceramic with low content of amorphous glass. Then there is ceramic with no amorphous glass. That means polycrystal, like one crystal glued to the another crystals. But when you have the ceramic with glass, you have crystal, and between those crystals you have something called the amorphous glass. That is the type of glass which have not exact crystal shape, and it can be etched with hydrofluoric acid. And when you etch it, you make a small grooves inside this hydrofluoric glass, and those can be etched adhesively. That means, if I answered well, you can, by doing minimal invasive, you are very much saving the vitality of the tooth, and you have a very low risk of causing a pulpitis to the patient, which will need for endo treatment. And if we have already endo treatment, we still try to do minimal invasive because we can save the enamel, and we will have a very good adhesion to the between the crown and between the tooth. Is it clear or not so much?
It sounded very clear.
Okay.
So thank you for any more questions.
Yes, please.
The next question is there external resorption?
Excuse me? Once again?
Hudaifa is asking whether internal bleaching cause for external resorption.
There is a lot of theory about that, to be honest. There is not a quite evidence-based science which will tell you that there will be this type, like external resorption after internal bleaching, because there is some studies saying even internal resorption can stop. But we know that extreme internal bleaching can have an adverse effect to the tooth. For that, we are not pushing it so much. We do it a little bit. We try to do the bleach, but if we see that it's not working, we are not pushing like just to bleach it out. Because some studies say, this is a very good question, it will make an external resorption, and some studies show you that there is even internal resorption. That means it's very hard to determine this, because you can't make there is some study on animals that's mean in lab, but which is similar to human teeth. But we know that it's a problem. For that, we don't push on it. That was a good question.
Thank you very much. We have another one.
Yes.
From Anna. She's asking whether you are working in the CR position. And if yes, when do you do an analysis to determine and choose how to fix it? Plus, which method do you prefer in registration?
Okay. If we are doing a simple restoration with, let's say, 1, 2, 3 crown, like really easy, where we have a very obvious occlusion, we just register the habitual occlusion. That's mean the centric, the habitual occlusion, the maximal intercuspidation. If we are doing a very big restoration, I do registration in centric occlusion. Centric occlusion mean that the jaw is in, the mandible is in the centric relation. When we have the mandible, the condyle in the centric relation, then we have the tooth, they are in centric occlusion. This is the new definition according to the Academy of Prosthodontic. If you go for the glossary of prosthodontic term at the Academy site, academyofprosthodontic.org, this is a website for the Academy, which I'm a fellow of this Academy in the United States. And there is a very good definition about everything. And last year, the Academy, we decided that the definition needs to be more clear, because it's really, sometimes people are interfering between centric occlusion and centric relation. Centric relation is the position of the condyle, and when the condyle is in the centric relation, we have the tooth in centric occlusion. I register my teeth, my occlusion in centric occlusion, when I'm doing a more complicated case, and I use the leaf gags. It's a small plates. When you put them in between your area of the incisional guidance, and you ask the patient to bite, you register. I don't have now the slides with me. I can, if you want, I can show you in some future webinar. I will be more than happy to show you this. It needs to show how to do it. But when I am registering centric occlusion, that's mean when I want to put the mandible in centric relation, I let the patient lay like this, and I never do this in this way. I put the patient in this way when I want the patient to know where the rest position. If I'm doing like a complete denture, we don't have a teeth, I do in it. But if I want to register a centric relation, I lay up the patient in the back, and I push his mandible to the back. This is how I do it.
Thank you.
It need more explanation just to show it on some.
Yes, of course. Yes, but thanks for the visual representation as well.
Okay.
We have another question from the time.
From I need to know from which country. If I don't know from which country, I will not answer. I need to know from where.
So no more questions.
No.
I don't know.
I don't want to have it all from Slovakia. I'm just kidding.
No. Okay, so the question is whether the non-impregnated retraction cord is for the first one, as the first one.
Yes, non-impregnated retraction cord is inserted in the sulcus as the first retraction cord during the whole preparation, just to retract the gingiva and not and to have more view of the border, the margin of the preparation. When you finish preparation and everything is finished, you put the second impression cord, which is impregnated, which is thicker. It's normally we have this 0, 1, 2, 3. I use the 3 for the impregnated cord. You insert it inside. You see one third is obvious, and this you remove it before the impression. And after you finish everything, you remove the first impression cord, the non-impregnated one. That one, when you insert it in the sulcus, you need not to see it. This is clear like this?
I hope it is. Okay. Next question is from William in Slovakia. He's asking whether you prefer high-frequency current or laser.
I don't use the laser, to be honest. Maybe I'm becoming a little bit old. I don't look like this, but I don't use the laser because it's expensive, and it's always, when it's something working for me, I just use it. I don't try to change it. When there is something not working for me, I try to use some alternative. The high frequency electric current is working for me. It's really very easy to use, very quick to use. The laser is slower. And for that, I don't need to change it. But I'm not saying that the laser is not good, not at all. But I don't have any experience with laser. And I don't want to make myself clever that I know everything. No, I only speak about stuff which I do on a daily routine basis in my office. I don't lecture stuff which I read only in the book, and I never applied it on a real life. For that, all the picture I show you is from my work. It's not from books, it's not from internet. This is what I think it's very important if somebody is lecturing. I don't have any experience about cutting and making retraction for laser. But from my point of view, when I was planning to buy the laser or not, I found that I don't need it. This is it.
Perfect. Thank you very much. We have another question. Who is asking what kind of...
From where the questions?
From Slovakia. We have many questions.
Okay, only from Slovakia.
So he's asking what kind of cement do you use for cementation? Or lithium disilicate or silicone crowns?
Okay, there is a whole presentation about how to choose the correct cement. I will say it in a very easy way. It depends about if you will use the possibility of etching the crown or not. That means if you are using a lithium disilicate crown, which is a ceramic with low glass content, there is amorphous glass, that means it can be etched. This type of crown need to be, or it's better if they are fixed adhesively. We will use adhesive cement to fix them. Even you will do the full adhesion process, that's mean etching of the enamel, primary of the dentin, seal, and then using a dual or one stage composite cement, resin cement. This is one part. But you can do this if you are able to apply rubber dam. You use this type of cement. If you are not able to apply rubber dam, and there is a danger to have moisture during cementing, then you need to use something more quick and more easy. In this case, it's better to use self-etched, self-adhesive cement. The cements which will do the etching of the tooth structure by itself, and it will then adhere to this tooth structure. That means if you can't put the rubber dam. But the problem with the self-etched, self-adhesive cement like Relay X or Maxen Chroma from Care or Relay X from 3MSP is the problem with it, they are very weak to etch the enamel. For that, when you see enamel, you take a phosphoric acid and you add it to the enamel and you etch the enamel additionally. If you see dentin, you should avoid etching the dentin with phosphoric acid because there are some studies showing that if you etch the dentin with phosphoric acid and after that you use a self-etched, self-adhesive cement, then you will have a very bad connection. There is only one study from Brazil showing that it is beneficial to do it. But you clean the dentin with conditioner, with tissue conditioner, the same one which you use it for glass ionomer. That's in any type of polyacrylic acid. It's a very low intense acid material. This is for lithium disilicate crown, but it's very quick, you know, you need to see picture and chemistry how it's working. For crowns which you are not able to etch, that means zirconia, metal crown, ceramic fused to metal. This type of crown, it's much more convenient to use non-adhesive restoration because you will not get anything from adhesion. Like the best thing will be phosphate zinc cement, the old type of cement, the phosphate zinc, like Harvard, or in Czech we have the Adhesor. Harvard is another brands, or you will use resin modified glass ionomer, RIM, resin, RMI, sorry, resin modified glass ionomer. I use them mostly. I use the resin modified glass ionomer. I'm not using anymore the zinc phosphate cement. It's very easy to use, very easy to remove residuals, and you get a very good result. If I am able to use the resin modified or the zinc phosphate, I'll be more happy than using the adhesion, the resin cement, the normal one, because removing of the residuals, cleaning the crown, it's so easy. When you use the resin cements, it's very difficult to remove all the excesses. For that, I use them only when I am able to etch the ceramic. If I'm not etching the ceramic, I'm not getting their benefit. For that, it's a lose of time and very hard for me to use them. For that, for crown which are not able to be etched, then the choice is conventional cementation like phosphate zinc cement or resin modified glass ionomer. It's clear?
Well, I think I personally need another lecture about it.
It's a very difficult issue.
Yes,
it's a very difficult issue.
complicated part. We have another question from
From
Who's
where?
from Jordan? Jordan.
Okay, from Jordan. Ahlan wa sahlan.
And she's asking whether in which cases you do any preparation
Where I don't do any preparation, like non-prep restoration. If I want to make some minor aesthetic changes and we see the border very clearly where my restoration will be, this is indication for me for do a non-prep restoration. The indication is very narrow, but if you collect them in a correct way, you will have a very good result. Like the same thing I show in one of the pictures. Sometimes I use them when I have spaces, tremats between the teeth, like we have spaces, and we don't do ortho. We just make a piece of the tooth like enamel and glue it and cement it to the tooth, and by this we close the space between the teeth. This is where I do the non-prep restoration. I don't hear well the questions. If it's okay, just ask me once again, and thank you for the question.
Okay. Thank you. Another question is from Stilke. She's asking when do from Slovakia.
Naozaj Slovensko. Okay.
When do veneers usually in case they're probably done?
Mm-hmm.
When do they have to be replaced?
Oh, when they crack out, when they don't look more beautiful, then you need to replace them. If they look nice, just keep them. It's a matter how you objectively evaluate them. If they look okay, just leave them. If they crack, look not beautiful, discolor margin, you need to remove them. I have some veneers more than 10 years in place and they are working fine. Sometimes I lose my veneer in 5 years. Statistically, in a 10-year, the successful rate of a veneer is something about 85% successful rate in 10-year period. This is it. But there is no any rule that force you to replace them with time. No. I have
no
some
expiration dates.
No. There is no expiration. It's not a yogurt. It's an inert material. It's a ceramic.
Okay. And she's also asking how to avoid impression. You already mentioned air, right?
You need to yes, and you when you put the impression tray, make this like moving a little bit up, down, little bit up, down, to side, and when you are inserting the impression tray. And by this, you will destroy the bubbles. It's a simple case, a simple way, and I think it worked very well. And if somebody tried, he will remember me that it was a good advice. Thank you for the question.
Another question from Sherry.
Yes.
From Sherry. From Egypt.
أهلا
Letter
وسهلا
in
بمصر. بأرض الكنانة.
Sorry.
In minimal invasive
Yes.
full crown
In minimal
preparation,
invasive crown preparation,
will the strength of crown be effective with the minimal reduction?
minimal reduction.
When you have, I show you at the beginning of the presentation, when you have enamel and you have adhesion connection, the study show from Cortellini and from like Petra Goose and other group from Germany and from Italy, that the thickness of the crown don't affect really so much the long life of the crown. This is it. Like when you adhere it well and you behave gently to the crown when you are trying them. It's also very important during etching of the crown. You know, the problem is that this topic, like from preparation, it's 2-day seminar. Now we put it all in 1 hour because, or 1.5 hours. It's difficult to put everything inside. But in general, if you do a full adhesion to enamel, don't be afraid of that the crown will break. Of course, if you have a bruxer and you are replacing occlusal plane in the posterior area, and you do for him really small occlusal veneer, it's a big issue and you can lose it. But you know, you need to decide if this is if it's suitable for this patient or for that patient. But in general, if you have a good adhesion, good cementation, don't be afraid by this. I have a case, I have hundreds of cases, and they are working just fine. Yes.
Awesome. Thank you very much.
Awesome.
For another
Thank you very much.
question.
Mm-hmm.
So I would like to thank you very much.
Thank you very much. And
Okay.
They're thanking you.
And they're thanking you.
It was a really enriching lecture.
Really enriching lecture.
Welcome you next time in our ID webinar.
It was a big pleasure for me to talk to you. I hope that the transmission, and at the beginning we have those small problems with technical problem, but I enjoy it. It is very strange to talk to the monitor, you know, the whole evening.
Everyone says that.
You need to take some marijuana maybe before that to be more happy, like you are doing something. Because at the end, I was like this Tom Hanks speaking to the ball, you know, the film on the island where his friend was the ball, and I felt myself like a Tom Hanks, you know, start to say hi to the monitor. He's my big friend. But it was a pleasure to me. I enjoyed it also. I would like to thank the organizer. It's a great job that you are doing it for the students, and hope to see you once again. Thank you very much.
Hope to see you too, and thank you again.
Okay, bye-bye.
Bye.
Bye.